To order. This is the Interim Joint Committee on Health, Welfare, and Family Services. This is meeting number 6. The date is Tuesday, November the 15th, 2022. Madam Clerk, please call the roll.
Senator Rocky Adams, Senator Berg, Senator Carroll, Senator Givens, Senator Harper Angel, Senator Howell, Senator Kerr, Senator Meredith, Senator Nemes,
Present.
Senator Wise, Representative Bentley, Representative Bowling,
Here.
Representative Bray, present. Representative Birch, Representative Dotson,
Present.
Representative Elliott, Representative Fleming,
Present.
Representative Frazier Gordon, Representative Marzian,
Here.
Representative Gibbons Prunty,
Here.
Representative Rayburn, Representative Raymond, Representative Riley, Representative Sharp,
Present.
Representative Sheldon,
Here.
Representative Tate, Representative Weber,
Here.
Representative Westrom, Representative Wilner,
Here.
Co-Chair Mosier, Chairman Alvarado.
Present.
16, exactly.
All right, we do have a quorum, barely, but so the first item on the agenda is approval of the minutes from the October 26, 2022 meeting. We have a motion for approval and then a second. All those in favor, please signify by saying aye. Anyone opposed? All right, the minutes are approved. All right, you see here we've got a variety of different things on the agenda today. We've got some testimony, I think, from 2 meetings ago regarding our PBM discussion that we had to table, and we're going to have those folks come back today and kind of present a little bit of information. The first thing I want to go ahead and address are the administrative regulations that are before you, and it's item number 7 on the agenda. Hopefully everyone's had an opportunity to review some of those. These have been before Administrative Regulations and Review Subcommittee. There is one that is of some interest, and there are some folks here to speak in favor and against one of the regulations that are here, and that is 907 KAR 001-104. Are there any other items that members wish to discuss? If not, right, seeing nobody, we do have someone who's here in the room. I believe Jennifer Wiseman is here with the Kentucky ANA. Ms. Wiseman, are you here? Yes, very good. If you'd like to come forward to the presenter's desk, introduce yourself for the record, and go ahead and speak to this regulation. Please make sure your microphone is on also and it's close to you. We always have trouble hearing.
Second. Okay, perfect. Good morning. My name is Jennifer Wiseman, and I am the immediate past president of the Kentucky Association of Nurse Anesthetists, and I'm here today to speak in support of this regulation. I'd like to just give a brief historical overview of how this regulation came about. I think it's important to understand the process that we've all worked on for this. Originally, back in the fall of 2020, the Hospital Technical Advisory Committee began discussing anesthesia billing issues. These were billing issues brought forward by facilities, not by providers. And the attempt to fix these billing issues is what got all anesthesia key stakeholders in this state brought to a table at the direction of Governor Beshear. So we had a meeting. All anesthesia key stakeholders in this state were present. That would be myself and another nurse anesthetist representing the Kentucky Association of Nurse Anesthetists, as well as the Kentucky Society of Anesthesiologists, the American Society of Anesthesiologists, and there were numerous facilities, their admin and legal teams, as well as people from the department. We were all at this meeting. And the outcome of the meeting was that the best thing that would solve these access to care and billing issues by the facilities would be to mirror Medicare anesthesia billing framework here in Kentucky Medicaid regulation. So we all agreed at that meeting, everyone was on the same page that this was going to be the fix for the problem that the facilities have brought forward. In order for that to happen, it was a 3-step process. The first 2 steps of that process were completed last fall with 2 administrative regs that went through relating to physician services and physician reimbursement. The 3rd step of the process is this reg and this one single billing code that only affects nurse anesthetists to mirror the Medicare reimbursement rate, which is 100%. That's all this regulation does. I think, like I said, it's important to know that everyone was at the table and agreed upon this plan back in April of 2021. This was a fix for a facility problem. This was never a provider-driven initiative. And this doesn't change anything about scope of practice. It doesn't change anything about how people work every single day. It doesn't change anything about safety. It doesn't change anything about any of the opposition that was actually brought forward during administrative reg review. So I just wanted to make that clear that this is just a reimbursement code, one of the 2 CRNA reimbursement codes. And it's been a long process to fix this for the facilities. And I'm happy to take any questions.
Thank you very much. Any questions from members? Yes, Representative Weber.
Ms. Wiseman, I just want to follow up and make sure we're clear on the testimony that I'm hearing from you. So it's my understanding that all parties that were affected by this were initially in the discussions. And
Yes,
at no
sir.
time there was any opposition raised.
That is correct.
And would you touch on federal funds that Kentucky may be in line to lose if we do not adopt this if we do not conform to this Medicare reimbursement?
Yes, sir. This was actually addressed at the top of the reg. And it is the policy of the Commonwealth, according to statute, to not turn away federal funds that are on the table. And when that got mentioned, it was brought up the last Administrative Reg Review Committee meeting also. These funds are already out there, and the additional increase in this reimbursement rate is not even going or paid to providers. This is paid to facilities or groups, and the facility or group is the person that is losing out on this reimbursement. It's not a provider directed payment.
Thank you.
Yes, sir.
Any other questions from members? Just a brief statement from me. I mean, reimbursement equals value is what it does. That's what's being changed here, is the value of what physicians provide. And that's the concern. And before you respond, I know you're anxious to say something, but that's what's being changed here. Again, I made a comment in Administrative Regulations Review Subcommittee. If you're a young person wanting to do anesthesia, there's going to be no incentive to do that here in the state of Kentucky at this point, because you're going to have Medicare reimbursements be the same, Medicaid be the same. Really, if you're going to be looking at it, it's decreasing the value of that individual. That's the concern that I've got here. And that's the problem with it. I know there's plenty of anesthesiologists I've talked to who've said that your claims about everybody being at the table is not the case, and we're going to hear from somebody here in a second on that issue. That's the concern that I've got here. I would imagine if someone was a radiologist and they were getting paid for what they were getting paid for services, and suddenly you say we're going to pay PAs equal to what a radiologist does for those same readings, and for that having involved them at all, you probably would have an issue with that. That's the concern that I've got. It would apply across the board to all specialties for that. That's the worry I've got here. Any other questions? Senator Burke.
Correct me if I'm wrong, but my understanding is that there are CPT codes for CRNAs only, CPT codes with observation from a physician, and they reimburse at different rates. What we would allow here is a CPT code that would reimburse a CRNA for their services without the 7 criteria that are necessary to use the higher CPT code. So it's actually up to the physician as to which code ends up being built. If the physician is in fact available for all 7 parameters, then that code would be built. If the physician is not, then this code could still be utilized. The facilities or the groups could still get reimbursed for the services they are providing to the hospital, to the facility, or the patient. It does not actually impact salaries of either anesthesiologists or physicians. That's a whole different discussion with contracts and billings and all that stuff. But all this, allowing this CPT code, which is a basic Medicare CPT code used all over the country, will only allow the facilities or the groups to bill for the services at a rate basically equitable to what they're doing. It doesn't actually impact anybody's salary. Is that correct?
That is absolutely correct.
So then I don't understand how this is going to disincentivize anesthesiologists who already make significantly higher salaries than CRNAs do. I don't understand. I mean, can somebody explain to me why we think this is going to affect their salaries?
That's a great question because I'm wondering the same. To reiterate how anesthesia billing works, and I understand the comments about value. Anesthesia is billed very differently from any other provider group. It is billed based on time units that you are, there's like a conversion factor of time and the procedure that you're doing. So there's a complexity times time times conversion factor. That is how anesthesia is billed. And what this regulation would allow, when you were talking about the 7 requirements, those are CMS mandated requirements to bill for medical direction of anesthesia. The former regs that just went through last fall reference the CMS manual for the specific documentation parameters that have to be met. If the parameters are met, you bill one way. If the parameters are not met, you bill the other way. I made this point, I tried to make it very clear during the last meeting. This code is not a CRNA practicing by themselves independently code. While it would be utilized in those settings and already is utilized in those settings, that part isn't changing. What this would allow is for facilities, bigger facilities, where we do work next to anesthesiologists every single day. If the anesthesiologist cannot come to the room with me to go to sleep with my patient because they are involved in another case in another room, the hospital isn't eating 25%. That's all this does. And if the 7 criteria are met on every single case, bill the other code. But if they're not met because the physician is tied up somewhere else in the model that we're working in, why should the facility eat the 25% or the group eat the 25%? And to say that this is gonna make salaries the same, this is already how we function every single day with Medicare. And if it were gonna make the salaries the same, with 1 million people in our state, we would not be making salaries less than half that of a physician anesthesiologist. There is no synonymous way to say that reimbursement rate equals salaries in this scenario. This is a cost that facilities are eating, and it was a fix for a facility-led problem.
Thank you, Ms. Wiseman. We have Dr. Bucks is on the line as well, so that's going to be our next presenter. She's coming to speak in opposition to this regulation. Dr. Bucks, are you there?
Yes, I am. Thank you so much again for letting me speak on Zoom. I think it's very important that one of us is heard.
Please,
are you able to hear me okay?
Yeah, we can hear you fine. If you can just introduce yourself for the record and then begin your testimony.
Yes, sir. Yes, sir. So my name is Dr. Bucks. I'm a practicing anesthesiologist in the state of Kentucky. Very quickly, I trained at UK, but I currently work in a community hospital, a couple of surgery centers. So I really kind of fully understand the different demands of a Lexington City sort of a institution versus what happens in rural hospitals and community hospitals. I do appreciate all of the questions that were brought up because I feel like they're going to tie in very nicely to our understanding of what's going on. Ms. Wiseman mentioned earlier that this code does not have anything to do with value. This code does not have anything to do with salary disparity. This code is just a modifier so we don't lose money. I feel like whenever a discussion like this comes about, where you are reimbursed for a service you provide, you always have to talk about who is providing that service, what is the training level of that person providing that service, and what are the outcomes. You know, it's very hard to have a conversation without bringing up, you know, training. I work very closely with all of my CRNA colleagues, and, you know, it's usually 1 or 2 physicians for about 8 of them. So they are our workforce. They're excellent at what they do. And this does not at all negate what they bring to the table. But the situation that we are falling into right now is we are using small little aspects of this is better for finances. This is better for the way to push this through so we can bill better. But we're not looking at that nobody ever talked about is, as a patient, if I walk in, if I'm a Medicaid patient and I walk in, then I am getting billed the exact same amount, whether a 6-year trained fellowship anesthesiologist is taking care of me or a fresh out CRNA with 180 hours of experience is taking care of me. And now we're talking about billing it exactly the same way. You know, I mean, it's difficult to explain how that can translate later into the value. If you're, you know, I'm going to use a completely different example for a completely different industry, because I feel like that will kind of make us understand. So if you look at the healthcare industry, if you look at the food and dining industry, you know, you've got your head chef, then you've got your chef, then you've got your sous chef. And that all of that is based on the level of experience, the number of years, the number of training. And this discussion does not need to be about that right now, because that's an entirely different conversation. But CMS already agreed to have the same billing code. We are also going to follow suit now and have Medicare and Medicaid follow that same billing code. When this happens, what is the incentive for hospitals? What is the incentive for other private equity like surgery centers to say, hey, we can bill the same, so why should we put more money in to hire higher level training physicians when we don't need it? And I think this is not to do so much about value and reimbursement just for physicians like anesthesiologists, but I also think this is setting like an example for all of the other specialties. You know, I'm about 9 years out of my training, and I speak to a lot of people from different countries, and also kind of compare and contrast where our landscape of healthcare is going. And I think that one of the big things I'm noticing is, as physicians, we put a lot of time, effort, and energy, took a lot of debt because we believed in having all of that training behind us, because that was what kind of gave us value in the entire scheme of the healthcare landscape, right? But now, if we have different types of backgrounds and different types of training, but we're assigning the same numerical value to it, then we can't distinguish that. And that brings me back to what Ms. Wiseman was saying, is that, you know, as somebody who is out, if I speak to a medical student, what is the incentive to work for 4 to 5 to 6 years to incur a debt, to be able to give up all of the monetary money that they're going to be earning in that time frame, and then to come out and then also work at a hospital where your reimbursement is the same? And essentially, at the end of the day, reimbursement does equal value. I mean, you cannot argue that. That's the only monetary thing that we can control and compare and contrast. I worry that, you know, Kentucky already has a shortage of physicians. Having such a rule pass is not going to it's going to de-incentivize people, because there's no reason to incur that extra cost. And you're also setting a precedence for all of the other specialties to follow. I know that, you know, we talked about PA and PA's leading radiology stuff. I mean, we're already kind of starting to see, you know, NPs in family practice, and we're seeing that. And that's, I mean, we need a full workforce. We need that. That's understandable. But at what point are we going to not look at the value that the training is providing? There's no value to go to 6 years of school when we are going to follow the exact same field and do the exact same thing. just as an example, I know we talked about, you talked about the 7 different modifiers and how you can bill differently. That's actually essentially not true in anesthesia. I mean, anesthesia is very complicated. But for example, if I'm taking care of somebody who's a healthy 27-year-old who is getting their appendix out, I will charge them the same as if I'm charging somebody who's had 4 heart attacks, who's a heavy smoker, who needs additional IVs and additional access. There's no pay difference between the two. But this modifier will allow us to pick and choose what we want to do and then get reimbursed the exact same way. To me, it just really devalues the extra years of training. And I don't know how else to look at it other than look at it from a monetary perspective.
Thank you, Dr. Bucks. I appreciate that. I know we've got a lot of other testimony. I've got a couple of questions. Representative Sheldon.
Yes, thank you, Chair. I guess this could be for Ms. Wiseman or either one of you at this point. But
Dr. Bucks.
yeah, thank you very much. I feel your concern there, and I guess I would ask Ms. Wiseman real quick. One of your main points for feeling like this is okay to make this change was that it would mirror Medicare. I think you mentioned that right off, and that's some of the talk I've heard. But I just want to bring up there's a lot of situations where Medicare, people would want to mirror Medicare, and then sometimes we want Medicare to mirror Medicaid. Mm-hmm. If you know what I mean. There's a lot of a lot of codes out there, and that goes back and forth. That argument does. It's like so to think that would be an argument, because if we use that argument and say, okay, well, the reason we should change this is because Medicare pays this way, then where does it stop? Where does that stop? And we could try to put this on an island by itself, but I don't see it that way, and I'm a little concerned with that. Now I'll go to question 2, and then you can answer them both, okay. or comment on them both.
Okay.
I'm a little concerned with what really happens in the trenches. For instance, you barely mentioned it, but you said it already happens. So, do hospitals just forego the additional money and not bill for the other CPT code, the one that you're trying to get, and they just go ahead and use what they're getting and get the lesser money? Is that what really goes on in the trenches, or do anesthesiologists get called in so that they can bill the additional code?
So to answer your first question about mirroring Medicare and that being sometimes a good thing and sometimes a bad thing, the reason it's a good thing for this specific scenario, I fully understand what you're saying, but this was brought forward by facilities. This was discussed at the hospital TAC, and this was an issue with Medicaid patients seeking care. It originally came from them going to facilities just across state lines, and the way that Medicaid was, as far as anesthesia billing prior to any of this starting, was there were only 2 codes. There was a code that says an anesthesiologist can personally perform the case themselves and they'll be reimbursed 100%. There was another code that said, which is this code, QZ, a nurse anesthetist can personally perform the case and it will be reimbursed at 75%. There was also a clause that was removed last fall that said medical direction will not be reimbursed by the Department for Medicaid. So when these patients were having problems getting care because they're going to these providers and those providers didn't even have an option for a code to submit, there wasn't one. There was only the 2 codes. And when you work in a team environment, you need more codes. So the fix was to mirror Medicare, because Medicare has all the codes that could be utilized for anybody. This allows anyone to get care, cross the state line if you need to. Wherever you're getting your service, they now have a route to bill. So that's why in this instance, it was important we mirror Medicare. As far as your second case about what happens in the trenches, we work in half the counties in this state independently. And we submit this code. The other half the counties, we work with anesthesiologists, and that's how our hospitals function. So in that scenario, if they are meeting the 7 TEFRA guidelines, which are very specific, then you can bill medical direction. That's definitely an option and a usable reimbursement code. But should one of those criteria not be met, the correct thing and the ethical thing is to bill this code, which is where facilities now, only with the Medicaid population, not even the MCO population, but only Medicaid, would default to this code. If they meet those requirements, they can bill medical direction. And Dr. Bucks was just talking that she works in a team environment. It's usually 1 or 2 anesthesiologists with 8 CRNAs. If there's 1 anesthesiologist and 5 CRNAs, guess what? They don't meet the federal criteria to bill for medical direction. So one of her CRNAs, that facility would be eating 25% because one anesthesiologist cannot medically direct 5 CRNAs and meet the criteria. So why, in that scenario, if she's busy and can't get to a room, or there's an added-on case where there's 5 CRNAs and 1 anesthesiologist, why are the facilities being forced to take 25% loss?
All right, very
Hopefully
good.
that answers.
Thank you.
Thank you very much. We have one more question. We've got to move on. We've got other topics to cover. Representative Moser.
Thank you, Mr. Chairman. I'll try to make this quick because I think you answered part of my question in your previous answer. My first question is, did the hospitals bring this forward?
The hospitals made the suggestion to the MAC that we mirror Medicare.
Okay. And so just to clarify, what's the incentive for facilities to continue hiring anesthesiologists versus a CRNA who cost them less to employ?
It's the facility's choice. It's the same reason they're continuing to hire anesthesiologists, and we work in teams every day when Medicare and private insurers already contract for this rate anyway. It's not going to disincentivize the hospitals. This is talking about less than 200 patients in this entire state. It's not going to disincentivize entire healthcare facilities on this specific population.
Okay, so the medical direction piece of all of this is somehow separate from how the hospitals hire anesthesiologists versus CRNAs? I mean, so there are stipulations in numbers of anesthesiologists who oversee CRNAs. Is that what I'm understanding?
Yes, sir. Yes, ma'am. There is a requirement. It is in the CMS manual that one physician, can you hear me? One physician anesthesiologist can medically direct 1, 2, 3, or 4 CRNAs. If there's 5 CRNAs and 1 anesthesiologist, one of those CRNAs has to bill this code, while the other 4 can bill medical direction, only because that is a rule for billing medical direction. Does that answer what you were asking?
I think so. Dr.
I'm sorry,
Fox, do you
ma'am.
have something that you want to
Yes, ma'am.
say?
I actually do. I just want to clarify that a little bit. There's medical direction and medical supervision. And actually the question you asked was the exact question I was going to bring up. So my facility, the hospital that I work in, even though Kentucky is an opt-out state and we have independent CRNAs that work independently, we still have physicians present to oversee stuff. We do not bill for medical direction. We bill for medical supervision, and we actually don't bill higher or get paid higher. The entire reason that we have this is just for patient safety and outcomes. Okay. So for example, if I have 4 rooms running and I am the person in charge there, I don't have to be there for every single case. But if there is a need that arises, if it's a higher acuity, higher morbidity patient, then we'll do it together. I'll be there for induction. I'll be there for extubation. Me being there or not there does not change that. But what is happening right now as we speak in my hospital, in my community, is that the hospital is now hired CRNAs independently. They're actually every single month are voting to change the bylaws so physicians do not need to oversee and be on call on the weekends. They're pushing for bylaws where they want 2 CRNAs instead of 1 MD at night. We have a bariatric program, we have a robust OB program, and we have a thoracic robotic program, the only one in the state of Kentucky, and we're still pushing because they're saying that they're not able to hire anesthesiologists. This comes back to the exact same issue that I talked about. 1, we can't incentivize anesthesiologists to move here, we're already short. 2, by changing this code, 70% of my patients in this hospital are Medicaid patients. So if the hospital now realizes that, hey, I can get 3 CRNAs for the price of 1 MD with the exact same service with these, there's absolutely zero incentive for them to pay for that money. The bylaws are changing as we speak every single day. And this is happening in my own hospital that we've been here for 35 years as a group, and this is changing. And the third thing is exactly what you said. Where does it stop? If Medicare and Medicaid are going to make these changes, what is to say that other insurance companies are not going to follow? I mean, already we've had pay parity on the table. We've already had independent practice. And this is just the third piece of the puzzle. So at some point, we need to stop looking at the smaller little pieces of what is this institution losing? How much money are we losing? And look at the broader picture of an aging, sick population in the state of Kentucky. And we are replacing higher trained physicians and paying the exact same amount to, and this is not just to anesthesia CRNAs, I want to be very clear, but this push, this change in landscape is happening throughout all the different specialties. Now, I can only argue about my specialty because what happens out there in that courtroom in 4 minutes is very different than what I see in my ORs every single day. So I feel very strongly about the fact that at the end of the day, value has to be somehow measured. Reimbursement is an excellent way to measure it. It gives a very, very bad message to Medicare and Medicaid patients that they cannot be equal with everybody else that has other insurances, that you do not get to have a trained physician. You do not have to get a cardiothoracic trained anesthesiologist, but you get what you get because the hospitals want to hire, I don't want to say less expensive help. And at the end of the day, like, it is what it is. I'm calling the spades, but it is what it is. If you were an institution that was for profit or not for profit, you were making the money, you would not want to hire a trained, fellowship trained physician where you could hire 3 more CRNAs to do the same thing. And that's where we're running from. And I think this change, for that reason, I think is more important because it's sending the wrong message throughout the healthcare field.
Thank you so much.
Thank you. I appreciate you listening.
Yeah. No, I think you very clearly answered my question and probably the question that everyone here has. And I mean, it's creating a perverse incentive for hospitals to hire less anesthesiologists when they can hire CRNAs. And it's at the end of the day, it's a bottom line cost issue. So thank you.
All right, thank you very much.
Thank
That's the kind of debate we had in administrative regs and regulation. Any other discussion for members? Otherwise, we've got other topics to discuss. Thank you all for being here, for presenting the information. Like I've said, I don't think it's a good idea. This is something that we're going to be looking back on, and it's going to be a gradual degradation. It's going to be a regret for us, so we're going to have a hard time attracting physicians to come to the state of Kentucky. All right, next topic on the agenda is, and that makes the record's going to reflect that we've reviewed these regulations. That's on the record as well. Next, we have item number 3, which is reducing patient costs through rebate reform. We have here today George Huntley and Julie Babbage, if you want to come forward. Actually, I think Mr. Huntley's remote, correct? He's testifying remotely. These are folks that were here to talk about our when we had our PBM day a couple months ago to discuss a lot of that. They had to be pushed off, so they're here to provide testimony we're planning on providing at that meeting. So if you'd like to, Mr. Huntley, if you're online.
I am, Mr. Chairman. Thank you very much for the opportunity to come back and address the group today. I know Julie is walking up there, and members of the committee.
If you all could introduce yourselves to the record officially and then begin your testimony.
Certainly will. And Julie, are you up there with the slides? Obviously, the slides are up.
Yes,
Very good.
Julie Babbage Longani, here on behalf of the Diabetes Patient Advocacy Coalition. And I've got joining with me George Huntley on behalf of the Diabetes Leadership Council and Patient Pocket Protectors Coalition. Just briefly about us, we are a diabetes.
You may want to bring your microphone a bit closer to you. It's hard to hear you there.
Sure. I'm going to go fast because I know George has a hard stop in just a few minutes, but just a quick introduction. With the Diabetes Patient Advocacy Coalition, we have thousands of advocates, patient advocates across all 50 states, and we work in tandem with the Diabetes Leadership Council, who works on the front end of policy with all 50 state legislatures. And today is not about diabetes, it's actually about an issue that impacts all patients. We formed a coalition with other disease states to promote affordability and access, starting with rebate reform. So I'm just going to briefly introduce George, who is the CEO of DLC and DPAC. He's been type 1 diabetes. He's had type 1 diabetes for 39 years and is an advocate for all patients. George?
Yeah, thank you, Julie. And again, Mr. Chair and members of the committee, I very much appreciate the opportunity to speak today. In my other day job, I'm largely a volunteer in this role. I am the plan administrator of a self-insured employer-based health plan. So I have 25 plus years experience of administering health plans from an employer's perspective. So I bring that to this discussion as well today. This list are the member organizations in the Patient Pocket Protector Coalition. The issue of the impact of PBM's behavior on patients is far beyond diabetes, and we formed this coalition just this year. So this is just the initial members of this organization, so that we can join our voices together on these issues impacting patients' pocketbooks and unfortunately also their health. Julie, why don't you continue us on? All right. You've seen this illustration of how a drug flows through the health system, if you will, from a payment perspective. I want to point out a couple of things here. First, at the consumer at the top, the ones we all should be caring about, the patients, they're paying an inflated list price for a branded drug during their deductible period. So the consumer's paying an inflated price. Let's start that with the first fact. The second is that same consumer has paid a premium to their insurance carrier or their health plan for access to that plan benefits, but they're not getting that plan benefit. So they're paying dues to Sam's Club, but they're paying Tiffany's prices while they're in the Sam's Club. So that premium isn't giving them a return on that investment, if you will, with regard to the drug benefit. The drug company at the bottom is paying a sizable rebate to the pharmacy benefit manager for access to the formulary. And this is often exclusive access. So that movement coming across the bottom on insulin, that rebate is greater than 75% of the list price of the drug. The average rebate is 48%, which means a consumer at the top, is paying on average nearly double what their insurance plan is paying for that same drug. So without getting benefit of that plan premium, if you will, for the plan design, they're paying double what their insurance plan is paying. Rebates moving over to the pharmacy benefit manager are largely passed up to the insurance plans. Now they're keeping a piece of it, and we'll touch on that in a moment. You've heard some health plans say, and this is, I think, even in the September testimony, that they are using these rebates to keep plan premiums down for all members. And I don't know of anybody who's had their premiums go down. I think we can largely agree it's having no impact whatsoever on premiums, and we'll touch on that as well in a moment as well. But they will even suggest that it would be unfair to do otherwise, to not share them across all plan participants. So they're keeping that pool of money. Now, our position, we respectfully disagree with that statement. It is in fact unfair to have the sick subsidize the healthy. It is reverse insurance. The many should help pay the costs of the unfortunate few, and not the other way around. The consumer who is buying the drug at the top there is quite specifically identifiable, easily identifiable. It's not a general pool of money. It's a very specific and personal payment being made by a patient. And that patient should be the one getting that benefit for that discount or that rebate that's happening here. Julie, why don't you move us forward? So here it's all in the family. All right. The PBMs in that middle row there, that second row, the Optum Rx, CVS Caremark, Express Scripts, they control 75+% of the US drug market. They have a lot of power. All right. They are also vertically integrated with the insurance companies, the specialty pharmacies, and provider services. That vertical integration is also creating a market behavior that is driving out independent pharmacies. And that is really hurting patients in the rural markets because they're not able to access independent pharmacies, which largely are the ones in the rural market. So it's an uncontrolled market environment, uncontrolled market power. Julie, why don't you keep us moving? This slide is coming from the state of Texas. The state of Texas passed a PBM transparency bill a couple years ago, and they just reported some of the findings. This is from 2021. The PBMs will all say that they are passing 95% plus of these rebates through to the plans. But this data, when you look at the orange line there, showing the PBMs hanging on to 13%, 21%, it's interesting how it's moving. Clearly it's saying the PBMs are keeping a sizable portion of this, a material portion. The green piece, which you can barely see on that screen, is the amount being passed through to patients, which is effectively nothing. And that's really what we're here to talk about today. Julie, keep us moving. The other piece here is this. It drives very perverse behavior of the PBMs. The lowest cost drug doesn't win. They're actually creating barriers for low-cost generics and biosimilars to be included on formularies. Now, this is Medicare Part D data because it's publicly available. However, it's the same PBMs that I just showed on that last slide. It's the same PBMs running Medicare Part D that are running the commercial plans and the Kentucky plans, et cetera. There's no reason to believe their behavior will be any different whatsoever. From 2016 to 18, 1 in 4 were included on the formulary when they were launched. Now, you would think they would embrace every single low-cost drug that would come out. Thank you. It's wonderful that you're here. They're not even being put on the formulary in that first year. In 2020, less than half were on the generic tier of the payment line on the formulary. So there is no incentive for the patient to actually take that lower cost drug because the PBM doesn't want the patient to take the lower cost drug. They actually want the rebate from the higher cost drug. These plans are not putting on the formularies. It's bad for patients because they're not getting access to the lower cost drug. And it's frankly, it's very much bad for the health plans itself and the state because you're not covering the low cost drug and you think you are. So that's an important point. We made this point, the average rebate is 48% on all drugs. And this is every drug out. This is not a diabetes issue. This is all chronic disease, all patients taking a branded drug issue. What happens with this? Simple math. $100 list price drug, the current state, the rebate's $48, the patient's paying $100, and that PBM and the insurance plan is getting $48 from that patient in January during their deductible period. With reform, the patient would be paying $52 as they ought, and the manufacturer is getting paid their net price. We also know that 69% of patients will absolutely abandon a prescription if the cost is greater than $250. So keeping these prices down is very important for patient health and patient adherence to therapy. Keep going. So the big question is, what's this going to cost? What's this going to cost a health plan? And, we've heard that passing rebates through to patients is going to be unaffordable. It will drive premiums through the roof. No one will be able to pay and afford healthcare coverage ever again. And unfortunately, this is a scare tactic, and it's simply not true. An actuarial study released this January, so this is new information, shows that the overall change in payer costs for rebate pass-through is less than 1%, 0.4% for the most common plan designs. It's negligible. It's rounding error. That study did not reflect any major medical savings by having actually healthier patients on the plans. Now, in the case of diabetes, and I will go back to diabetes, but it's true in many chronic disease states, it's the heart attacks, it's the strokes, it's the amputations, the end-stage renal disease, the blindnesses. These are the things that cost plan dollars. The drugs aren't the big thing that's driving healthcare costs. It's the complications and the ramifications of poorly controlled chronic disease. Express Scripts themselves, one of the top 3 PBMs, in June of this year, came out with a study which they ran, capping the cost of all diabetes medications, not just insulin, but all diabetes medications. Because people with diabetes there's many drugs out there to address diabetes. You cap that cost at $25 a month. That cap resulted in a lower overall cost of diabetes care of 16.3%. That 16.3% overall plan savings was driven by reduced hospitalizations because the patients were better controlled, right from the PBMs. This is a scenario where we will likely save money by passing through rebates at point of sale. Now let's look at it from another perspective. Okay, the drug spend is the tail wagging the dog in a health plan. Drug spending is around 10%, maybe a little bit higher, but it's in that 10 to 15% range of overall healthcare costs. 85 to 90% of a plan's cost are the major medical cost. It's the hospitalizations, the surgeries, all of those things, the lab, all of that work, the doctor visits. That's where the primary dollars in a healthcare spend come from, not drugs. The purpose of drugs are to help reduce the costs on the other side. So reducing the spend on drugs is a tail wagging the dog scenario. Now we know that branded drugs are the aspect of the drug part of the plan where the rebates come into effect. You don't have a lot of rebates on generics. Rebates on specialty drugs don't matter because they're so big they meet the deductible immediately anyway. It's the branded drugs where this really comes into play. That's 28% of the drug spend. It's 2.8% of the overall healthcare costs. It's impossible statistically for passing through rebates to escalate healthcare costs in a material fashion. And you also have to understand that you're only passing through rebates during that finite period when the patient is in their deductible. So it's not the entire plan year. It is that finite period in the first quarter or so when the patient is meeting their deductible. That's what we're talking about passing through rebates for. It is far more likely that you're going to save money by overall plan savings from better, healthier patients.
And just briefly to touch on our legislative principles, so we're working on legislation with lawmakers who want to impact the cost of prescription drugs by working on rebate reform. So for us to support a bill, we ask that at least 80% of rebates be passed through at a minimum, that copays are calculated based on the net cost of the medication, not the list cost, and that there's a penalty for noncompliance. So thank you to Senator Meredith for legislation this past session on this that met all of these criteria. Thank you, Senator Chair Alvarado, for your support of that. Senator Sheldon, just for all the work you've done on transparency and on this issue. I want to recognize our Attorney General Cameron, who signed on to a bipartisan coalition of attorneys general to regulate PBMs because he wants to hold them accountable. And also just briefly recognize our own Congressman Comer and the role that he's played federally to bring attention to this through the Oversight Committee. And with that, I will turn it back over to George for our last slide.
Yeah, just in closing, PBMs were created for medical billing of pharmacy transactions. That was their purpose when originally created. They don't make anything. They don't touch anything. They report only to their shareholders. They don't have a fiduciary responsibility for the health of the patient at all. United Healthcare had $24 billion in 2021 earnings. That's their earnings. That's not their top line. That's their bottom line. $24 billion. Over half of that was from their PBM subsidiary, OptumRx. This is big business, guys. Patients are being harmed by PBM's business practices. Patients pay a premium for access to a club that is still closed off. And patients need your help. Patients are helpless. They can't battle OptumRx. They can't battle United Healthcare. They need your help. And so I appreciate very much the opportunity to speak today. Thank you, Mr. Chairman, for affording us this opportunity. We urge you to continue your deliberations. And I apologize that I have got to run, but Julie, I am sure, will be very happy to answer questions as we go.
Thank you, Mr. Huntley. It's a very good presentation, actually very clear and succinct. And it's infuriating, and I'm a provider, and I can tell you we see costs of, everything go up, price of premiums go up every year, and the accusations this is going to cause If you do this, it's going to cause an increase in that. And I think the estimates were $3 per member per month, $3.25. Medicaid did this, and we went ahead and took care of this problem when we realized savings 10 times that amount to the system. So it's clear, and that's all money that suddenly has been used by the governor to expand services in Medicaid, because wow, that's how many millions of dollars have come in from this. I've already been told by some of our insurance partners they're going to take us to the mat on this. They're going to fight tooth and nail. So I'm anticipating a very nasty fight on this, but I think the proof is already in the pudding here in Kentucky on Medicaid, and it's already been shown that it's going to work, and it's going to benefit patients is the bottom line. One of the things I want to talk about also is I used to, as a doctor, patients would come in to see me. I prescribe them a generic medication. And I know that generic medication would be $4 at Walmart. And they'd go and they'd come back and say, actually, they charged me $10 for a copay. And I'm like, what? Because they did it through their insurance company. That money went back to their insurance company as profit for them. And so what I started telling them is, don't bother reporting it to your insurance. Don't tell your insurance company that you're getting this. Buy it on your own. Don't give them your insurance information. And if you pay for it cash, it's 40% of what it would have cost you if you had gone with that over a generic medication. That happens all the time because of these negotiated rates. When I get somebody coming in to see me and the insurance company says, I want them on Prilosec, January 1st next year, you know what? We want them on Prevacid this year instead. Okay, I change them over to another medication for their stomach medication, only to have the following January, you know what, doctor, we'd rather have them back on Prilosec. Talk about confusion for me, for the patient. It leads to compliance issues, all kinds of problems for this kind of stuff, and it's become nonsense. And one of the things I've often talked about, and maybe Mr. Huntley briefly, I know you got to go, but one thing I've often talked to these insurance companies, instead of negotiating all these backroom deals and negotiating rebates that they keep and robbing from their own customers, why not just offer a voucher system where they could say, you've got diabetes, we're going to give you X amount of dollars to spend on the medications. You and your doctor sit down, just like when we have a donut hole situation at the end of the year with Medicare Part D plans, you sit down and figure out with that budget, what can you get with the amount of money that we've allotted for you? And then pharma will have to bring their price point down to match those costs. And it's a natural kind of, almost a free market type of mentality to drug cost containment to offer vouchers. They can contain their costs of what they know. Patients and doctors call the shots, and no more of this backroom negotiations. Maybe I'd like to get your thoughts on that.
Well, you'd have to create another marketplace because the consumer has nowhere to go to get Prevacid or Pravastatin, which are different drugs. But they don't know where they're going to go get that. They're going to CVS or Walgreens or their community pharmacy. And for them to be able to set that price and where they're going to get that, there's got to be a market mechanism for that. I don't disagree at all that creating that separate market mechanism would make a lot of sense for patients, and getting outside and breaking the whole rebate system, because it just inflates things for the benefit of only the PBM. It's just a matter of how do you go about really doing that.
Yeah, maybe it just takes some people, some entrepreneurs and some guts, and maybe Kentucky needs to be the place where that gets started. Senator Meredith.
Thank you, Chairman Alvarado. Just to, I guess, reiterate some of the points you've already made, is when I filed this legislation last session, it was immediately killed by employers who were going to our respective leaderships and saying this is going to cost us a fortune. I remember one employer in particular said this is going to cost us $7 million, and I'm thinking to myself, it's your money to begin with. This is the ultimate Ponzi scheme if you look at how it's structured, and these scare tactics are what's keeping us from passing effective legislation that truly helps the most vulnerable. No one should make a fortune off the misfortune of others. That's exactly what's happening. This is really falling on our most vulnerable. And here's a chance to right this wrong. Now, I understand how corporate America works, and insurance companies have to make a bottom line. They're responsible to their shareholders, but there is a point where enough is enough. There's got to be a balance here, and presently there's not a balance. This is a terrible situation. It is actually stealing from people. There's no other way around it, and I would hope and pray that through this presentation today, and those who aren't on this committee, that other members will share this information. I know we'll have a chance to talk about it again when we come in session 2023, because I'm filing the bill again, but this needs to be done. We have to do something to reduce the healthcare cost to the average consumer, and this will do it. I promise that it will, but we need this legislation. Thank you, Mr. Chair.
Representative Sheldon.
Quickly, just full support for the legislation, of course. I don't know why. I think Mr. Huntley really puts it in perspective when he said PBMs were created, and it was like late 1960s, but to just simply form a connection between the insurance companies and the pharmacies. The internet wasn't too long after that, and that all came about. And in those days, we paid 10 cents a transaction. And then we managed to get it down to 4 cents a few years later. And those companies were called Envoy, NDC. There was only two in the entire nation. What I'm trying to say is they evolved into these Fortune 500 companies by creating some dilemma that they actually do something other than an IT switch connecting two people together. These outcomes and these things that they talk about, they change them like the wind. We'll get 5 outcomes this year, be 5 different outcomes the next year. There's no, so I'm going to make it one step simpler than Senator Alvarado. I'm going to say go back to a fee transaction, pass through, and if they want to charge 10 cents or quarter, just let us know what you want to charge per transaction. And let's get rid of the rebates because we're just never going to ever reel them in. But this is a good start. I think you'll see some legislation next session that will have to do with all the money going back to the premiums except for a reasonable amount. So we'll leave it at that. Thank you very much.
Representative Mosier.
Thank you, Mr. Chairman. Thank you for this presentation. I have a quick question, and it's probably a really long answer, but if we are able to pass some legislation to control these rebates and do some rebate reform, how will the 340B program be affected?
From my perspective, I don't believe it will impact it because we're talking about passing through rebates in what would be considered a commercial plan that would impact Kentuckians. So you're talking about the state employee benefit plans. You're talking about the plans through the exchanges in Kentucky. Anything that is addressed by the insurance commissioner within the state, if you will. The 340B program is designed for patients who are in the poverty levels and things like that. That doesn't impact the incentives there. It also doesn't impact the pharmacies' ability to purchase those medications for those 340B patients from the drug companies. That doesn't impact that. That transaction doesn't get in the way of that transaction at all. So it really should have no impact on 340B.
Okay, thank you. I mean, I appreciate that clarification. Is it not true that the 340B program, I'm trying to figure out how to ask this question, is expanded now to facilities versus individuals, and that they also are incentivized to use the higher cost brand name drugs?
I'll give you what I know. Okay, so the 340B, that's all I can give you. The 340B program is a follow the institution or the pharmacy and not the patient. So the pharmacy has the ability to purchase this drug at 340B prices, and so they then can turn around and sell that drug however they really want. And some very good players, if you will, good community pharmacies, et cetera, for the low income are passing most of those discounts through, and the patients who really need it can get it. And there are some egregious players that are taking that drug that they're buying for $5 and charging $150 for it. And so that absolutely is happening today. This law won't help. This issue of passing rebates through to a commercial patient won't impact it. But a separate dialogue on how 340B is playing out in the marketplace, it has gotten out of control. And the numbers of pharmacies and institutions that can purchase through the 340B program have grown exponentially over the past decade. to the point where naturally when that happens, people are trying to make a buck, and it winds up getting exacerbated and a bit out of control, similar to what this rebate situation is today as well. That's worthy of a conversation. I'm not exactly sure how to address that in this environment.
Mm-hmm. Okay, thank you so much. I appreciate that very much. I think you're right. It is worth a separate conversation. Thank you.
Just to add, we had worked with the White House and the Trump administration, and obviously there is some federal play here to reel that in. But as George said, if you're getting the medication for pennies on the dollar and then turning around and selling it for much more to our most vulnerable citizens, that's absolutely a problem. There are certainly people who are doing it the right way, but there are entities that need a greater regulation for sure.
Great. Thank you all very much. Appreciate that presentation. Next on the agenda, we have Mr. Jim Musser, who I think is with the Kentucky Hospital Association. Jim, if you'd like to come forward, and hopefully it's a very brief discussion on pharmaceuticals and white bagging, also part of the discussion that got postponed from 2 meetings ago. Jim, if you'd like to introduce yourself for the record, and we've got 2 other presentations after you, and we've got a hard stop at 1 o'clock. We have another committee needing this room, so please introduce yourself and begin your testimony.
I am Jim Musser. I am the Senior Vice President for Policy and Government Relations with the Kentucky Hospital Association, and your wish is granted. My comments are going to be mercifully brief.
Excellent.
Let me start by saying good afternoon to you and to Chairwoman Mosier and the rest of the committee, and thank you so much for having us. This is an important issue. But before I get to the white bagging, I'd like to talk a little bit about a Greek lesson. And I know that may sound very strange for the Committee on Health and Family Services, Health and Welfare to be talking about Greek lessons, but there's an important concept involved in what we're going to be talking about. And if you don't remember it for too long, that's okay, as long as you remember it while I'm here with you today. And that concept is the Greek word telos. The telos of something, and there can only be one, whether it's an individual or an institution. It is the one thing for which it was created. So if we're talking about a knife, the telos of a knife is to cut or pierce something. The telos of a seed is to bring forth a new plant. And the telos of the hospital is to care for the patient. And so everything that the hospital does revolves around that. That's the guiding star. That's the North Star. Whatever else we're doing, it's all going back to taking care of the patient. And I'm so glad that in listening today, both to your questions and to the other presentations, that it really has been patient-focused, because that's where this all needs to be. For me to serve the telos of our hospitals, it's important for you to learn about this practice of white bagging. It's small but growing, and a number of states have already been trying to make sure that they get it under control before it gets completely out of hand, because what it really involves is the patient's health and safety. White bagging is a process by which the PBM requires the insured person to use a pharmacy owned by the insurer outside of the hospital to provide drugs that typically are going to be infused into a patient, either a rheumatology patient or a cancer patient. There are others as well, but those are kind of the primary ones. The drugs are mailed from the PBM-owned pharmacy to the hospital, where the hospital then prepares them for infusion, and the hospital administers the drug to the patient. The white bagging process is actually subject to a number of safety concerns that could result in either an ineffective, at best, or dangerous, at worst, treatment for the patient. There's potential waste of very expensive drugs, and it potentially disrupts the patient-provider relationship. Could we show slide 2, please? The way the treatment process typically works is that medications are going to be delivered by a licensed distributor to the hospital to ensure the pedigree and integrity of the cold chain. It also ensures that it's in compliance with the Federal Drug Supply Chain and Security Act. As you can see in the slide, the process for treatment starts with the diagnosis and creation of a plan of treatment, which is then entered into the patient's electronic health record. and that step helps to provide some safety checks, and it provides medication information for the providers. The prescription requirements are sent to the hospital or health system's pharmacy, which then prepares the medications for infusion on the day of treatment. Prior to that treatment, there's another clinical consultation to ensure that those drugs that have been prescribed are still the right ones, that there hasn't been a change in the patient's status that would require an update to the treatment plan. Then after that consultation, the patient receives the proper infusion of medication. Slide 3, please. With white bagging, drugs are shipped via mail order pharmacy to a hospital to administer, and they go through alternative distribution channels. There's no guarantee, there's no control over that. The medication package could be misplaced or lost, and there's no guarantee that the products have followed the critical cold chain requirements. Things could end up sitting on a loading dock and later being moved on. And if the drugs weren't properly stored and the provider isn't aware, there are safety concerns for the patients. And quite frankly, if we harm the patient by doing that, there are liability concerns. And who's responsible for the liability if we had inadvertently harmed a patient? For many infusions, the patient's required to have the lab work done prior to the infusion to ensure the therapy is appropriate and the appropriate dose is administered. Next slide, please. If the patient's lab value indicates a change in therapy is necessary so that the dose or product now indicated is different than what was white bagged, several things could possibly happen. The therapy can be delayed, which can be disastrous for the patient. The very expensive dose may be completely wasted. And the facility may make the determination that because treatment is urgently needed, they will use their own stocks from their own pharmacy to create the drug and infuse it right then, and then they're not going to be reimbursed for that by the insurance company. Slide 5, please. White bagging can also lead to patient access issues. Many health systems are safety net organizations, and it's within their mission to ensure patients have access to medications regardless of their income. By removing the safety net organization from the procurement and billing process, providers lose the ability to make sure that patients who face financial difficulties really have the ability to afford the medication. Large mail order pharmacies do not share the mission of safety net providers to ensure patients can afford their therapy. It's simple as that. Under the white bagging model, inventory control costs will increase for the provider, who bears the cost of intake and storage. It increases equipment costs, their staff and facilities cost, all without compensation. And ultimately, that's likely to have an adverse effect on the patient's access to care. Really, the bottom line is when white bagging is a threat to health and safety of patients, that's not the right way to go about treating them. White bagging skirts the protocols designed to ensure patients get the right treatment at the right time and creates a climate where liability for patient injury is really unclear. It's simply a concept that's focused far too much on the insurer's bottom line rather than the patient's health. To return to the Greek lesson very quickly, we have to ask ourselves, what is the telos of those who are demanding white bagging for the patients? Their telos is different from the hospital. Is their ultimate purpose to serve the patient, or is it to serve the bottom line of the insurance company? It's not wrong to make a profit. We don't hate the insurance companies. We want them to be profitable. Their telos is different. It's to serve their shareholders, and that's a good thing. It's what's made our society prosperous, and we want our patients to have health insurance. We want them to be covered. We want them to have the ability to cover their treatment. But the success of the bottom line can't be the price of health and safety for the patient. Looking at you in this room, it's so easy because you have been such great partners in caring for our patients. We would ask that you continue to work with us to serve our telos of caring for the patient. As I often say to you, every one of our patients is one of your constituents, and we want the best outcome for them. So please work with us as we try to address this issue and make sure that we get a handle on white bagging before our patients are damaged. Thanks again for having me. If I don't get another chance to speak to you before then, hope everyone has a very happy Thanksgiving. Despite all the bad things going on in the world today, we really do have a lot to be thankful for in this country. I am thankful to be here and thankful for your attention.
Thank you, Mr. Musser. Appreciate your comments and your presentation. In the interest of time, I think we're going to move forward to the next one. But that's, again, look for some of this information. It was in last year's bill, and probably be finding some language regarding this topic moving forward in the bill that will probably be presented in the upcoming session as well. So thank you very much. Next, we have item number 5, a discussion of the 2023 regular session. It's a bill request 203 relating to cost sharing for prescription drugs. We have Dr. Dave Almeida, who's the Government Affairs Director. I think he's on remotely as well. Mr. Almeida, if you're there, if you'd like to introduce yourself for the record, and please begin your testimony.
Thank you. Thank you, Senator Alvarado, Representative Mosier, members of the committee. My name is Dave Almeida. I'm the Regional Director of Government Affairs for the Leukemia and Lymphoma Society. And I appreciate the opportunity to speak with you regarding the challenge that's facing many patients, which is the high out-of-pocket costs associated with the medications at the pharmacy counter. By way of background, the Leukemia and Lymphoma Society represents the over 1.3 million blood cancer patients and survivors across the United States. Our mission is to cure leukemia, lymphoma, Hodgkin's disease, and myeloma, and improve the quality of life for patients and their families. The problem that we are trying to address is the high out-of-pocket cost sharing for prescriptions, which is too high for many patients to access the medications they need. This is compounded by other drug benefit design features such as co-insurance and high deductibles and copays. Here's how this works. Insurance carriers use 2 vehicles to pass on the cost of medications to their patients. One is called a copay, which is a flat fixed dollar amount. The other is called co-insurance, which requires the patient to pay a percentage of the total cost of their medication, which could be hundreds, if not thousands of dollars. So to summarize, copays are by and large within the financial reach of patients, whereas co-insurance is by and large outside the financial reach of patients. What we know about patients when they are not able to afford their medications is that they engage in behaviors which are not conducive to good health outcomes. They may ration their prescription, say, by example, take 1 pill every other day as opposed to 1 pill a day. They may take their prescription as they're directed for 30 days and never return to the pharmacy to have that prescription refilled. Or worse, they may walk away from the pharmacy counter without that prescription. The solution that we are offering to solve this problem is as follows. We are asking the insurance carriers that half of the plans they offer must be copay only. We go further and cap those copays at $100 for silver, gold, and platinum plan per prescription per month, and $150 for bronze plans per prescription per month. This would apply pre-deductible, which is very important because it means that the patient can benefit from the copay prior to meeting their deductible, and it applies to all carriers in the individual and small market. Graphically, this is how this plays itself out. Again, without protections, patients pay full cost until they max out their deductible. With protections, per prescription spending is steady and predictable, and that's what's best for patients. Essentially, the bill would allow the patient to use 2 criteria when selecting a health plan, not just one. They can select a health plan that meets 1, their medical needs, and 2, their financial needs as well. And with that, Mr. Chairman, I will conclude my remarks and take any questions you may have.
Thank you very much, Mr. Almeida. I appreciate that. Any questions from members of the committee? You should have a copy of a bill draft there, and it's something for us to review, and open to taking any feedback as you review that. It's a very brief bill, but this is a real problem, particularly people that have a lot of chronic illnesses and a lot of malignancies. It becomes a real big topic. Any questions from members of the committee? Representative Mosier.
Thank you, Mr. Chairman, and thank you very much for your presentation. I have a quick question. Do the caps, the copay caps, would they apply to an individual's deductible?
So they would apply to the deductible, but under the bill, they would the patient would be able to take advantage of the copay prior to meeting their full deductible. But yes.
Okay. And this would apply to Sorry, I haven't read the bill.
Okay,
Leukemia and lymphoma, or any?
No, to all chronic conditions that have to use especially medications that are particularly where we see the particularly use of coinsurance. So it's not just exclusive to leukemia, lymphoma.
Okay, thank you.
Thank you.
Any other questions? Yes, Representative Sheldon.
Just quickly, the caps that you're talking about putting on the medications, is that per individual per month? Or it sounds to me like the way it's written, it's per drug, per single drug per month. So if I'm on 3 drugs in a particular level, whether bronze, silver, whatever, each drug is going to be susceptible to that cap. Is that right?
That is correct, yes.
Okay. All right. So, all right. I get it. Thank you.
Thank you.
Thank you. Any other questions? Mr. Almeida, thank you for your brevity and for a succinct presentation. We appreciate that.
Thank you for your time.
Thank you. All right, and last on the agenda we have today, but definitely not least, is a presentation on the Aware Recovery Center. We have Mr. Brian Holzer, who's here, if he wants to come forward. And Mr. Holzer, if you want to introduce yourself, or Dr. Holzer, should you introduce yourself for the record, please, and begin your testimony whenever you're ready. Make sure your microphone's on. You want to hit the little bar and make sure the light lights up.
Let's try this again.
That's good. Very
How's
good.
that? Chairman Alvarado, Chairwoman Moser, members of the committee, thank you very much. I'm honored to be here. My name is Dr. Brian Holzer, CEO of Aware Recovery Care, and I'm very excited to be able to introduce our company, which is coming to Kentucky here in a few short weeks. I've been in healthcare my entire career. I'm a medical school graduate. I did a year residency. I went on to get an MBA, and I've had the privilege of working for many great companies, the last of which brought me to Louisville, Kentucky, where my wife and 3 kids now call home very proudly. But Aware Recovery Care is different. There's a greater purpose and a mission and a meaning for me for this company. And it is a company that's changing lives in ways that I think we all can appreciate given the growing epidemic with regards to drug addiction. I want to talk to you a little about the company and the company journey. We are an in-home addiction treatment company. This is a people-first, in-home-first company. We provide in-home care for folks and their families recovering from addiction. We do it with a full clinical care team that includes licensed professionals, addiction psychiatry, psychotherapy, care coordinators that are either nurses or social workers, and they surround and support a team of paraprofessionals that will include certified recovery advocates, as well as family educators. This is a model that's delivered over the course of a calendar year. And ultimately, our mission is to heal at home, and we do believe we do so over the course of that year. We are a pioneer with regards to this model. This is a model in which we believe we're the only scaled provider delivering this care thus far in the country. We also believe that we will not be the last, as folks continue to recognize the home as an important level of care with regards to the recovery from addiction. The company was founded in 2011 in Wallingford, Connecticut, by our founder that is now the chairman of the board. He was a gentleman, 25 years sober, working in pharmaceuticals, literally had a dream one night of a better way to deliver addiction therapy, woke up, quit his job, ultimately worked with a Yale researcher to develop the model that's very close to the model that is there today. He ran 5 patients through the model in the early days. The 5th patient is now our co-founder and is a direct report of mine in the company. In 2015, the company had 50 employees and 100 clients in one state delivering the model on a fee-for-service basis, at which point Anthem of Connecticut stepped up to the table and provided a monthly bundled rate for our services. Again, our program is a year in length, and the way the monthly bundled rate works is any member that is on the service for more than 14 days on a given month, we receive payment on a total monthly bundled rate that is inclusive of all the care we provide over the course of that month. That opened the floodgates, so to speak. We now have 16 value-based contracts that include big named insurance companies like Blue Cross Blue Shield of Massachusetts, as well as Florida Blue, and Anthem has been continuing to support our expansion as we move from early days of Connecticut to New Hampshire and Maine, and ultimately they've supported our expansion to Indiana, Ohio, and soon to be Kentucky. Fast forward 6 years, as I said, we were 50 employees and 100 clients in one state. We're now 750 employees. We are going to have an active census approaching 1,800. We're on pace to do almost 3,500 admissions next year alone, and we're just getting started. Those 750 employees, 525 of which are direct care providers, they are living heroes. 90% of them are in recovery themselves. And as part of their journey in recovery, they wake up every day to contribute to the recovery of others. And that develops the true culture and the outcomes that I'll speak to you with in a second. In 2 weeks, we're having ribbon cutting in St. Matthews, outside of where I live, to celebrate our 10th state, which will be Kentucky. And I'm proud to say moving forward that Louisville, Kentucky will be the new regional headquarters for Aware Recovery Care. It's important to note that currently our population is commercial only. We serve 18 to 65. We have 16 value-based contracts, all on the commercial side of the equation. I am so thrilled to bring this to Kentucky, and I believe all of the elements are in place for us to use Kentucky as a springboard to be able to launch into additional populations, both on the Medicare side and the Medicaid side, which you all know all too well that that is a population that needs this even more than the commercial population from a sheer numbers perspective. I also want to spend a few minutes talking about why we are so different and why our model is so unique. First, the home is our treatment center. We have no physical locations, nor will we have. We send our care teams into the homes. Often the care teams will start their day at 5 p.m. because that's what's going to be most convenient for folks with work, family, and school responsibilities. Because we're in the home, there is no reentry that you would typically see with higher levels of care. And what I mean by that is when you remove someone from the home and you put them into a recovery center, while that may be what works for that individual, you are removing them from the home with the environment that often is the contributing factors to the addiction in the first place. They're housed well, they're cared for well, they're fed well, much like a hospitalization, they're stabilized. And then you're sending them right back into the home with absolutely nothing changed in the first place, with the underlying issues that led to the addiction in the first place. We are in the home. Over the course of a year, we're able to peel back the onion, so to speak, what's below the iceberg as we talk about in our company, and ultimately get to the root causes leading to the addiction. We end up healing the home and creating sustainable recovery. We treat addiction like a chronic disease. That's very important. I have looked at our model. I have no background in mental health or behavioral health, never worked in the space. My background's in post-acute and home and community services. But I often look at how we're delivering this care, and I say we should be delivering this type of care for all chronic diseases. Addiction is a chronic disease, no different than heart disease. And it's a lifelong disease. And there are three elements to our model. We have a medical component, a behavioral component, and a peer support component. Those three elements together make us unique when you look at all the models of care that are in the traditional models. We aim to heal the home, not just the client. We have an entire dedicated track to the family. The family are crucial allies to the importance of the sustainable recovery for the individual. We're in the home. Obviously, our target population right now is an employed individual with stable housing. We do believe this will apply to a Medicaid population. It will require member selection with regards to though with some form of housing. We go into dormitories on the school front, and we're absolutely able to deliver this in a manner in which we're not interrupting work, school, or family, and ultimately we can heal the home. As I'll talk about shortly, our model does include in-home detox in our first phase. That detox can start on a Thursday and end on a Tuesday, and in a confidential, anonymous fashion, someone can continue with the care in their home and not miss a day of work. As you can imagine, from an employer standpoint, this is a no-brainer. From labor, this is a no-brainer, and we've been well received in all of the markets that we've gone to, thus after the expansion from Connecticut. Lastly, because of our monthly bundled rate, this is a value-based, risk-based contracting model. We have upside and downside risk written into our model. We believe in taking risk. We believe that we're delivering on the triple aim. We believe in the cost, quality, and patient experience of our model, and we're willing to step up to insurance and take risk on our end to make sure that we're ultimately on the hook just as much as the insurers for the outcome of that member going through addiction recovery. Real quickly, I won't go through the details of this slide other than to say we have a 4-phase model. It's a loosely speaking because recovery for one individual is recovery for one individual. The path to recovery will differ for each individual, and our model is flexible. Loosely speaking, the first 2 phases are 6 weeks in length. The third phase of more in a maintenance phase is 6 months, and the last phase of a community engagement is more of 3 months. What I want to highlight is more, if I just leave you with the following, the quotes at the bottom of each of the phase. The nuances and the articulate nature of this model is such that the founders, even back in 2011, ultimately looked at a broken traditional levels of care in that they're not stitched together. And my background, again, is post-acute. It's the same thing on the hospital post-acute side. Someone stays 5 days in a hospital, they're stabilized, and then they're discharged, and they may get touched by 4 or 5 different companies in 90 days, none of which talk to each other, all of which are incented on a fee-for-service basis. Addiction is no different. And so what the Aware Recovery Care model does is it stitches together the levels of care into a continuous longitudinal chronic disease care model. Think of it as residential treatment without walls, connected to PHP or partial hospitalization without walls, connected to intensive outpatient without walls, connected to outpatient without walls, and all flexible with integrated care management and support along the way. The other way I describe it is addiction is, as many of you know, is more like an EKG pattern. There's periods of engagement and disengagement during the natural course of recovery. When you don't have a longitudinal care model, when you have periods of disengagement, you have high risk for relapse and ultimately another level of care. We are a no discharge model in which we're caring for that individual over the course of a calendar year, therefore can manage periods of disengagement. In fact, when there are periods of disengagement, we have an entire team dedicated to engaging the disengaged. Those team members are called client engagement specialists. They do nothing but engage the disengaged. And we have about a 25% recapture rate of folks that are disengaged that will get back into the engagement and ultimately complete our program. Last 2 slides, I just want to highlight our outcomes, which are unparalleled because of the nature of our program. There really is no comparison because there are so few models that will wrap this amount of care around a member for a longitudinal period of time. We get measured by our insurance providers by retention rates. Think about it also as a completion rate. And so when you look at folks at 6 months or 24 weeks, 2/3 are still on our service. That is 6 months after the start of the program. At 12 months, we still have more than half of the individuals that have completed the full 12-month program. There will be appropriate completions prior to 12 months of folks that have reached their treatment goals. And so it's not that we aren't completing 48%. It's that 52% of folks are still on our service in need of our program and are going through the full 12-month program. The course for someone starting with detox will be closer to 12 months versus someone that has already been in a facility for 30 to 60 days may not need the full 12-month program, and we will customize it with that regard. These are unparalleled completion rates that you will not see in the treatment industry because, again, and I've worked for insurance and I've worked for hospitals, and I really appreciated some of the earlier discussion. You need 2 things to create sustainable change in healthcare, in my experience. You need clinical transformation, you need payment reform, and they need to work together. You need both. And ultimately here, we have a model that will work with both sides in a fashion that I think both sides can be successful. This is truly a model that can deliver on the triple aim: cost, quality, outcomes, and patient experience. And I believe moving forward, starting with the state of Kentucky, we will make the leap from a commercial population and be able to work copacetically with the Medicaid plans in the state of Kentucky and be the very first state to be able to put this in the homes of folks with Medicaid insurance in the state of Kentucky. Lastly, I just want to speak just a bit about the post-treatment outcomes. These are the types of things that predict for sustainable recovery. These are the types of things you would want to look for. These are also types of things that would load into a risk-based contract with an insurance company to hold us accountable for delivering on those outcomes. Nearly 80% of abstinence 6 months after a year-long program. Now you're talking about 18 months after they start the program. Because we're in the home and we have a dedicated family wellness track, we're seeing almost everybody report improvements in their family dynamics. We cannot forget that the family is in crisis also. And ultimately, when the client decides to pick up that phone call and seek recovery, their family is in crisis also. And so our model is dedicated to not only healing the client, but healing the home, and is a very, very big part of our model, and that supports those efforts. The last phase, the maintenance phase, or our community re-engagement phase of our model, is entirely dedicated to giving the client the tools and resources to support sustainable recovery in the community. And so we work very hard to create connections to AA, NA, and other community therapy groups. As you see, our engagement with PCPs is very high. And again, as I've seen in healthcare, ultimately, if you cannot have a longitudinal care provider following that member, you have a strong chance that whatever you've spent on is going to regress back to the mean. When we get our patients, the engagement with the PCP is in the teens. When our clients leave our program, it's nearly 90%, and that supports giving them the best shot for sustainable recovery in sort of a lifelong sense. And let me conclude with some outcomes. Anthem has been following us for 6 years now with their own actuary department, not ours. And we get sent this data, and ultimately, obviously, it has supported their desire to see us in more markets for them in more states. What you don't see on this slide is, and I'm happy to show you it in a separate forum, is we have demonstrated total cost of care reduction on a PMPM basis, not just medical, but behavioral, and not just the year that they're on our program, but the year after they're off our program, suggesting sustainable recovery. What you're looking at here is Anthem data from 3 states, about 400 people, the tail end of 6 years of measurements. And what they measured is the utilization of higher levels of care, using that cohort to determine the cohort that started on the WARE program, where they were as a baseline. And what it demonstrated is a 61% reduction in utilization of higher levels of care during the year that they were on our program. But what you see here that I have rarely seen in my entire healthcare career is that those outcomes are sustained even after our services stop. And in healthcare, as you all know, things tend to work when you throw a bunch of resources at something. And things tend to stop working when you pull those resources away, and folks tend to regress back to their baselines. That is not so with Aware Recovery Care. And that is why Anthem is so excited and supportive of our expansion across more markets. So let me conclude with the following. I feel very strongly, been involved in a lot of different things. Again, I worked for Amgen on the biotech side. I've worked for Large Blue in Pittsburgh, as well as Health System, and Kindred Healthcare is where I moved here for Louisville. I've seen a lot. I haven't seen anything like this. I do believe that Aware Recovery Care is going to change the conversation with regards to how we view addiction treatment. We're here to partner. We're not here to threaten traditional levels of care. 2/3 of our census comes from referrals from higher levels of care. And we spend a lot of time care coordinating referrals that we cannot treat due to insurance to our partners in the states that we enter. We're here to partner. We're here to be part of the conversation. And again, this is one of those wonderful topics where you don't need two sides to the conversation. What's good for members of this committee will be good for insurance companies, will be good for hospital systems, will be great for patients. And I look forward to continuing the discussion with members of this committee to make sure we get this in the most amount of homes possible. Thank you very much.
Thank you, Dr. Holzer. And we had a chance to talk privately. This is very exciting. I mean, we've had a lot of discussions about the need for transitional housing with people that go through substance use. I've shared that one of the directors for Isaiah House, which is a big kind of provider in the state and with really good success rates. But the difficulty is once they get discharged is that housing issue and that transitional problem that continues to be a problem for a lot of folks out there. This is exciting, and the numbers are exciting. And so I think there's going to be some. We have an opportunity. There's a lot of money being thrown at this problem right now in the state. There's a lot of grant money available. That this would be something I think for them to be able to take a look at, also at the Attorney General's office through a lot of the opioid abatement task force and the grants that are coming every year. So there's some really neat things.
May I comment on that real quick? We're actually working with a nonprofit right now who has approached us to submit for the opioid abatement dollars. We would be a sub to the nonprofit to be able to deliver the care model in the home. We're putting together a care model with that nonprofit. I think is going to be first in class with regards to our ability to actually enter the Medicaid market and improve out our value. And so we're working very hard with local nonprofits to be able to appropriately tap those grant dollars in ways that I think will reflect the value we can deliver in new populations.
That's phenomenal. Representative Mosier.
Thank you, Mr. Chair. Thank you for being here. And we've also spoken privately. So I'm excited about this model. I just have a quick question. You currently work with Anthem. Do you have other partners? And can you explain kind of your current payment model?
Yeah, we have 16 value-based contracts that reflect contracts with insurers in the various states that we operate. So Florida, as an example, would be supported by Florida Blue. I can't mention it today, but we have a very large national insurer that we're about a week away from signing. It'll be a second insurer for Kentucky as well. Blue Cross Blue Shield Mass, Tufts, again, 8 or 9 large payers across the states. On a fee-for-service basis, our model would be $40,000 to $42,000 over the course of the year. I don't want to draw any comparisons from residential treatment, but you can do the math in terms of recidivant rates and the cost of various treatment. We feel very good about our pricing model. From the monthly bundle rate purpose, which is reflective of all of our bundled contracts, the rate that we receive in each of the phases reflects what the insurer is used to paying for that level of care. So what they're used to paying for residential treatment in phase 1 roughly reflects the rate that they'll pay for our model. And then it tiers down over the course of the 4 phases to reflect the lower amount of intensity as someone gets from active crisis into maintenance. Now, those rates don't reflect the fact that we're providing a fully loaded, coordinated longitudinal care model. It is just, as you think about in the early days of showing value to a payer, they're used to paying for X in residential treatment. The care model itself loosely reflects in terms of intensity what they're used to seeing in those phases, and that has driven the construction of the monthly bundle rate on an insurer-by-insurer basis. Thank you for your support.
Very good. Representative Raymond.
Thank you. I'm excited too. I've got somebody in detox right now at Baptist Hospital,
Yeah.
Within a mile of your house, probably.
Yes.
So I wanted to ask you about that intensive phase 1, the intense phase that you called residential without walls. I'm just wondering about you all not being able to control that environment, and especially in that phase, how you deal with the fact that the clients could still access the drug.
Look, that's something that continues over the course of the entire year. And I think ultimately, of all of the heroes that we have on our direct care staff, keep in mind, we have 90% of those in recovery, and we assign 2 peer recovery advocates to every client. They're called certified recovery advisors. I will add, many of these folks do not have degrees, have previous felony convictions, and are going through their reclamation phase of their life. And ultimately, when you send someone in that is previously, that is not in a white coat, I've worn white coats, there's a place for that. There's not a place for white coats when you walk into someone in active crisis. They will respond to the credibility of someone that has been there, that looks like them and was them not too long ago. And that's what they receive with regards to those 2 peer recovery advocates. Those folks know where the bottles are hidden. They know when they say, I haven't been drinking, and they're already back looking in the garbage can and see the empty bottles. They know all the tricks because they were there just not too long ago. And it is that intervention with someone that is not a threatening, and I don't mean it this way, but it's not a traditional healthcare provider. It is someone that looks like them, that can walk into the home and said, look, I don't know if what worked for me will work with you, but we're going to find it. And it's that level of connection that leads to, I think, our outcomes and sort of the sustainability of the model, particularly early days when the risk of someone using is high. The other thing I will add is if someone falls off the wagon, so to speak, and starts using it again, there is no shame bestowed on the individual by the care teams. This is very much a situation where it does happen, and our folks, from a very empathetic perspective, will work to get the individual back essentially on the path towards recovery. And that is not always the stance taken by traditional levels of care and group therapy providers. And so there's no panacea. Absolutely, folks will ultimately relapse. We do see folks go to higher levels of care during the course of our treatment. But I do believe we're offering a best-in-class new option for clients. It's going to deliver outcomes that I don't think the addiction community has seen to date.
Great. Thank you. Representative Westrom.
This is very interesting.
Oh, thank you.
I'm wondering about staffing. I would think it would be very staff intensive.
Yes.
But it sounds like you're including people who have been through the programs and are an example and also know what to smell and what to look for.
Yes. No one in their right mind would create a model like this today. You wouldn't get funded for it. This is why you don't see many of these models, and I'm not sure you'll see too many of them moving forward. I don't believe this is a model. I don't believe the intensity of service providing lends well to virtual or telehealth. It is a component of our model. We support it because not everyone wants to see us 3 days a week in the home. But ultimately, we're a people-first, in-home first model. As a result, it is labor-intensive, and part of the reason why I was brought on is to build this in a scalable fashion that can be done in more markets, and profitably so moving forward. I think what I have seen, because I have no background on this, I get to learn from all the wonderful people in my company, is the treatment community is very tight. And the friends and family referral situation with regards to employees is very strong. Our former chairman goes to meetings with my head of medical affairs. It's just part of the community and the ethos with regards to our company. As a result, you see a lot of friends and family referrals with regards to that. With that said, in Kentucky, we are working very closely with several nonprofits to be able to build up the workforce development piece of this. It is a very big selling point to new markets that we enter in. Not only are we able to treat a hard-to-treat population of people, but we're able to also recruit, train, give people jobs of hard-to-employ people. I've got people that have living miracles, turned their lives around, former heroin addicts that were homeless, that then ended up meeting their wife in detox, and then ultimately working for our company and now equity holders. That is one of many, many stories of folks. So we have a path here where we can employ hard-to-employ people, give them the career track, and ultimately give them part of their sustained recovery will be their ability to contribute to the recovery of others, and that's what we stand for. So there is, every home care business is dealing with staffing issues. I just think we offer something different. And as word gets out, I believe we'll be a destination of choice for folks that want to contribute to this recovery community.
Great, thank you. Any other questions from members? Dr. Holzer, thank you. We look
Thank you for the
forward
time.
Thanks for moving to Louisville. We appreciate you being here now. So we've talked a little football before too. So I know we have opposing teams this upcoming week, but looking forward to a good matchup, and welcome to Kentucky. We're looking forward to hearing more from you and the success you're having on these
Thank you. I
programs.
really appreciate the committee's support.
Thank you. All right, that's the last presentation. Before we conclude, I have a few remarks I want to make. So I think we're not planning on having any further meetings for health and welfare in December. So this is likely the last meeting, and it's the last meeting for health and welfare ever, really, because after some changes, at least in the Senate, we've and I think it's going to happen also in the House, there's going to be some changes in the committee structure. So we know how we rank on child abuse as a state, and we're trying to devote more time. We know that these meetings are not quite the meetings that Representative Birch used to have years ago, where they would go 5 or 6 hours. We're pretty limited on time frames anymore, probably no more than 2 hours. And so in order to be able to dedicate more time to a lot of child welfare issues and family welfare issues, we've divided it up. At least in the Senate, we're going to have now a Health Services Committee and then a Family and Children Committee moving forward. So as far as the structure of this committee is how it's always been, this is the last one we're ever going to have. So let me start off by saying it's been my absolute honor to serve on this committee with all of you, with the staff. It's been very dedicated, really the unsung heroes of Frankfurt, a lot of the staff, that all the magic that happens at these committees, making sure the microphones work, that the cameras are working, that the people are online, able to dedicate all that, happens because of these individuals. So I want to thank you all for your tireless effort and work, making sure that our bills are done properly on time, and handling a lot of our neurotic requests when session is in. Thank you all for that. And really thank you all really also for serving on this committee. I know I have a lot of passion. I know all of you have a lot of passion when it comes to healthcare issues, and it always comes through. And I've taken a lot of pride, I think, in the things that we've been able to accomplish. There isn't as much partisanship here. I think a lot of this is mostly policy. It's trying to make sure that we do good things for the healthcare outcomes of the people that we represent in the state. And I think we've done a lot of good work, and there's more work to come as these committees change. And so many of us might be on different committees split up. Who knows? There might be some chairmen coming out of this committee as well that'll be serving as well. I want to recognize a lot of members that are going to be they're retiring effectively from the General Assembly today. We've got 6 members that have been members of this committee for a long time, and a lot of great work and a lot of selfless commitment to the people of the state as well. I know Senator Alice Forgy-Kerr, I know Alice was here earlier. I know she had to depart. Tremendous work, and Godspeed to her in her retirement with her and her husband. Representative Birch, I know you want to make a few remarks. I'm going to let you make some here in a few minutes, sir, but many, many years here. In fact, you may have been here when this committee was founded. I don't know. But to be perfectly honest, I know there's been a lot of hours of testimony that you've heard and a lot of policies we've gotten done because of your hard work and commitment to the state as well. Representative Mary Lou Margian, I don't know if Mary Lou's still here, but she was here earlier. Obviously a nurse and a stalwart in her beliefs in defense of Louisville and in the practice of medicine and nursing in the state. Representative Melinda Gibbons-Prunty as well. Melinda, we're going to miss you. And she's been great here as well. And Representative Steve Sheldon, one of our pharmacists, also is going to still help us in trying to get some bills drafted, I think, moving forward for next year. And then Representative Susan Westrom also, a fellow colleague in Fayette County. All of you, have a chance to get to know all of you. A lot of you are providers and folks who are dedicated to this. It takes a special individual to serve on this committee. I think a lot of our colleagues sometimes don't want to sit through a lot of the testimony. It's very emotional sometimes. People have to express themselves, and it takes special people to enjoy this. I think that all of us enjoy this, the testimony. It can go on for 2 hours, and we don't get bored. I think a lot of times, and we can hear a lot of things and learn a lot of things. So thank you all. It's been my absolute honor to serve with all of you. Representative Birch, you want a few remarks?
Thank you, Mr. Chairman. One is, first, I want to say what an honor it's been to serve with the members of this committee. And I wish you all the very best in the future. Out of my 49 years as a legislator, 47 of them was a member of this committee. and I had the honor of serving as its chairman for 30 years. So we made a lot of progress in those times. But one thing I do not want to forget is the staff. They were the backbone for many of the things I was able to do. And in fact, they, you might say, they encouraged me to do some of the things I did. But I'll miss this place, but I'm also looking forward to spending some time with my grandkids and my great-grandkids and some of my friends that's still left. And thank you very much, Mr. Chairman.
Thank you, Thank you, Representative Birch. Representative Mosier.
Thank you, Mr. Chairman. And I just want to echo the sentiments of Chairman Alvarado and just say what a pleasure it has been to work with everyone in this configuration of our committee. I'm not exactly sure what's happening on the House side, but we'll continue working for great health policy and great changes here in Kentucky. So I just want to echo the sentiments and thank everyone for all of your work. And we're going to keep some of our friends who are retiring on speed dial and just, continue working hard as we always do. Thank you also to our staff. I appreciate greatly all that you do and all that you put up with when we are fast and furiously drafting and working on policy here in Kentucky, especially during the session. So thank you all. We will see everyone in January.
Thank you. Proud of the work that we've all done here, and thank you for all your commitment to the Commonwealth. Unless there's any other comments, we stand adjourned.